Hello everyone, this is Chelsea, and I will be presenting my comprehensive differential diagnosis project on both vestibular migraine and Meniere's disease. But before I jump right on into both pathologies, I thought it would be interesting to just Google both of them and see what sort of definitions Google can provide to pretty much anyone with any sort of internet access. So, according to Google, Meniere's disease can be defined as an inner ear disease that typically affects one ear. This disease can cause pressure or pain in the ear, severe cases of dizziness or vertigo, hearing loss, and a ringing or roaring noise known as tinnitus. When someone is to type in vestibular migraine into the search engine, they are provided with this definition. Vestibular migraine is a nervous system problem that causes repeated dizziness or vertigo in people who have a history of migraine symptoms. Unlike traditional migraines, they may or may not have a headache along with the vestibular migraine. While both of these definitions are typically not wrong, there is a bit more to the story for both of these pathologies. So, to jump on in, let's start with Meniere's disease. Just like many other pathologies out there, Meniere's disease doesn't just have one theory behind its cause, it has quite a few. The first theory is that it is thought to be associated with an excessive amount of endolymph within the scala media, whether the endolymph comes from an overproduction, an underabsorption, or just poor flow through the endolymphatic duct. The next theory, that is quite similar to the first theory, is that it's an abnormal accumulation of endolymph within the endolymphatic sac, which results in the membrane tearing and the endolymph and paralymph fluids of the inner ear mixing, which can result in a flutter of symptoms, most of which I will go over in just a bit. A third theory that is, again, similar to the first two is that it is an altered endolymph chemistry and the person's inability to maintain a homeostasis of that chemistry within their ear. And while those are some of the more researched theories behind Meniere's disease, there are also some recent research that suggests it can be caused by a cellular channel dysfunction and ion conductance disturbances, or it can be caused by a fluctuating sodium level that can trigger cellular dysfunction. And lastly, and probably most recently, Meniere's disease has been linked to an autoimmune dysfunction, and that can be due to elevated levels of autoantibodies and antigens. But all that being said, when it comes down to the incidence and prevalence of Meniere's disease, it is said to be quite controversial. But according to Berlinger in 2011, there are about 218 cases of Meniere's disease for every 100,000 people. It is also said to develop most commonly in women between the ages of 35 and 60, but it can also develop in men, and it can develop outside of that age range. But what I find to be the most important statistic is that while not everyone is able to manage their Meniere's disease, about 70% of people with Meniere's disease are able to do so with a conservative medical treatment, and some of those are things that I will go over a little bit later as well. And while Meniere's disease does not have a set list of risk factors, it does have some common triggers like a high sodium diet or a large intake of caffeine, a large intake of alcohol, or a large quantity of smoking. Even high levels of stress and or fatigue can be caused to trigger Meniere's disease. Meniere's disease can also occur completely out of nowhere, completely spontaneously, but about 20% of sufferers have some sort of family history of Meniere's disease. And this is actually supported by research that has linked multiple gene defects to Meniere's disease. But the ultimate question is, how do we know whether or not someone should be diagnosed with it? To start, patients who suffer from Meniere's disease tend to come into the office with 4 classic symptoms. The first one being recurrent episodes of spinning and vertigo that can last anywhere from just over 20 minutes, but typically no more than 24 hours. These patients also tend to have a fluctuating hearing loss that is progressive over time, but most commonly presents as a low-frequency sensorineural hearing loss with poor word recognition. The next classic symptom is an episodic tinnitus that is typically described by these patients as a roaring sound. And the last classic symptom of Meniere's disease is an episodic oral fullness or pressure in their ears. While these are the 4 classic symptoms of Meniere's disease, it is possible for people to experience other symptoms as well as other forms of presentations of Meniere's disease. For instance, as I mentioned, it is generally affected in one ear, but it can affect both. In fact, there have been studies that have shown that half of the people who have had Meniere's disease in one ear for at least 15 to 20 years will eventually develop Meniere's disease in the opposite ear. Attacks generally involve severe vertigo, imbalance, as well as nausea and vomiting. These attacks are typically incapacitating. They don't really get out of bed much. And on average, these attacks can last about a few hours. And while attacks are spontaneous and recurrent, they can occur either in clusters of episodes, or each episode can occur years and years apart. But between attacks, many people are symptom-free or experience a mild imbalance in tinnitus. And like I said, they are incapacitating, and they can also have recruitment and or hyperacusis while in an attack of Meniere's disease. When it comes to our testing, generally we see on the audiogram a progressive sensorineural hearing loss with poor word recognition, which is something I mentioned before. But sometimes Meniere's disease is classified in 4 different stages according to the pure tone average of 500 hertz, 1000, 2000, and 3000 hertz. And those stages and classifications are listed there for your reference. And as I mentioned, they do tend to have poor word recognition, but typically their word recognition testing is even worse when they are experiencing an episode of Meniere's disease. Another thing to note when it comes to the audiogram is the general configuration. In the beginning, as mentioned earlier, it is set to be a low-frequency sensorineural hearing loss, but with the progression of the disease is a progression of hearing loss, and over time that hearing loss configuration can move from a low-frequency configuration to sort of a more tent-like configuration, with the peak of the tent being at 2000 hertz, and from there on it would, generally start sloping more and more profoundly. But eventually the configuration of hearing loss will appear as a flat, severe hearing loss, sensorineural hearing loss for these Meniere's patients. When it comes to other audiologic testing, such as otoacoustic emissions, the results of that tend to correlate with the amount of hearing loss the person is experiencing. Emittance testing typically shows type A tympanograms or normal. Reflexes are, again, generally correlate with hearing loss, and they show no evidence of reflex decay. To continue on with test results, their ECOG can show an enlarged summating potential, but it is important to note that many of these patients may have a normal presentation on ECOG if they are not currently dealing with an episode. So if they are in between attacks and they come in, there is potential for the ECOG to show up as normal. Auditory brainstem response testing, or ABR testing, is typically only done to rule out a retrocochlear involvement. Therefore, the inter-peak latencies and the intraoral wave latencies are generally within normal limits. If you are to test a Meniere's patient with vestibular evoked myogenic responses or VEMP testing, they tend to show a reduced or absent response in the affected ear with the Meniere's disease. You can also perform a VNG or ENG on these patients, and depending on whether or not they are in the early phases of Meniere's disease or later phases of Meniere's disease, you may get different results. In early phase Meniere's disease, you may see it is considered an irritative lesion, meaning that the nystagmus beats towards the involved ear, and they may show an enhanced caloric response in the affected ear. Those with later phase Meniere's disease tend to show a hypofunction, as well as nystagmus that beats away from the involved ear, and a unilateral weakness with caloric testing. But again, something to also note is that if you are doing this VNG testing in the very, very beginning of Meniere's disease, it is possible for the VNG to come out as normal, especially if it is between attacks. So again, you are going to see the biggest change in test results if the patient comes in when dealing with an episode which, due to the fact that it is incapacitating, can be very difficult for patients to do. So that's just something to keep in mind. These patients may also go through some general medical evaluations to sort of rule out other things. And this can be done in the form of blood testing, which is used to rule out syphilis, general infections, thyroid dysfunction, etc. They can also undergo imaging such as MRI or CT scans to rule out retrocochlear lesions as well, similar to that of the ABR testing. Ooh, sorry. All that being said, Meniere's disease is known as a chronic condition, meaning that there is no cure for it, but it can be managed. And typically when it comes to managing Meniere's disease, physicians tend to start off with the most conservative approach, which is general lifestyle modifications, such as limiting sodium intake, caffeine intake, and alcohol intake. Another lifestyle modification that people can do is just managing their stress levels and living a healthy lifestyle, such as getting enough sleep, daily exercise, a healthy diet, etc. To continue on with the more conservative approaches, there is potential to be prescribed medication to these patients. These medications can be either vestibular suppressants or anti-nausea medications that are to be used during an episode of Meniere's disease. They can also be prescribed diuretics for long-term use, which are aimed at reducing fluid retention. And also they can be prescribed oral steroids, which are also used during the attacks of Meniere's disease. To continue on with a less conservative approach are middle ear injections in the form of steroids, which can be used to reduce inflammation, or gentamicin, which is vestibular toxic, but it is used to reduce vestibular function in the affected ear. And what that sort of does, it sort of just dampens the vestibular system in that ear in hopes of reducing the vertigo symptoms that the patient is experiencing. Patients can also get something called the Meniere device. And what that basically does is you have a PE tube placed in the ear, and you put the device up to your ear, and it applies a repetitive low-pressure pulses to the ear multiple times a day. There are also surgical options for Meniere's disease if none of those more conservative methods work. One of the surgical approaches can be a vestibular nerve section, which severs the vestibular portion of the 8th cranial nerve. The downside of this surgery is that you risk losing some, if not all, of your hearing. People can also undergo an endolymphatic sac procedure, which attempts to decrease fluid production, or it can increase fluid absorption. And then people can also just have ablative surgery, such as a labyrinthectomy. If patients have severe chronic balance issues, they can also go through vestibular rehab with a physical therapist. In my opinion, vestibular rehab can be used especially for those patients who sort of experience more imbalance and unsteadiness between attacks, more so than the people who are completely symptom-free, just because you want them to be able to go about their day without, major risks of falling, and which would result in them hurting themselves. So vestibular rehab can be beneficial to those patients. When it comes to audiologic treatment for people with Meniere's disease, you would most likely want to get them hearing aids. The type and style of hearing aid is dependent on the hearing loss as well as configuration and patient preferences are also important when picking hearing aids. But some things to keep in mind when it comes to hearing aids with patients with Meniere's disease is that you probably want to pick a hearing aid that has the option of having multiple programs, especially since this Meniere's disease is progressive and or a fluctuating hearing loss. So if it's fluctuating, you may want to give the patient multiple programs within their hearing aids that are sort of set at different volumes, even if all the other settings are exactly the same. You might have one program that's slightly louder or slightly softer instead of giving them a volume control. For some reason, some patients like that over the option of volume. If it's a progressive hearing loss, you would want to make sure you pick a hearing aid that has a lot of headroom, just in case the hearing loss progression does get worse and worse in short amounts of time. Another audiologic treatment that can be discussed with patients is different types of tinnitus intervention. Again, the type of intervention would be dependent on the tinnitus severity. But for those with more mild tinnitus concerns, you might just recommend that they get a sound generator, or they might just get hearing aids with a tinnitus feature in them. For those patients who suffer a more severe tinnitus, you might, discuss something like a progressive tinnitus management course or cognitive behavioral therapy or other types of tinnitus interventions. But all that being said, Meniere's disease can be managed with hearing aids and tinnitus when it comes to the audiologic part of treatment. Next up is vestibular migraine. It is the second and last pathology that I will go over today. Just like Meniere's disease, vestibular migraine does have multiple theories behind it. It is thought to be a migraine equivalent, and migraine is a neurological disorder which is often inherited and can be associated with several different chromosomes and genes, some of which are listed for you here. The CACNA1A gene is a lymphatic migraine, and it typically has an aura around the migraine with the vision. But some of the other non-inherited theories behind vestibular migraine are vasospasms, which are vascular constrictions. And what can happen there is blood vessels dilate, and when they overdilate, they impinge on the nerves on the blood vessels. And during the ischemic phase of the headache, blood flow may be constricted, including to the internal auditory artery, resulting in a vestibular migraine. It is also thought to be caused by a central nervous system depression, meaning large ions such as potassium, calcium, or others suppress neural activity. Some trigger causes the cellular changes to spread outwards into the brain, causing a suppression of blood flow, again resulting in a vestibular migraine. It can also be due to the release of certain neurotransmitters such as neuropeptides or serotonin. Neuropeptides are what cause dizziness. They are excitatory to the inner ear sensory cells and to the vestibular nucleus. They can release asymmetrically, therefore provoking the dizziness. Serotonin tends to affect the vestibular nucleus firing rate, which can, if not at a general level, can cause vestibular migraine. And vestibular migraine can also be linked to calcium ion channel disturbances. Vestibular migraines are more commonly found in females between the ages of 20 and 40 years old. Generally, people with vestibular migraine, 11 to 18% of those with vestibular migraine are women, whereas 4 to 6% are men. But both children and adults can be affected. And something also important to note for those female patients with vestibular migraines, the symptoms tend to correlate with their menstrual cycle. Typically, it's just before the menstrual cycle. But something to note would be that diagnosis of vestibular migraine is typically made in the early 20s, with the greatest number of episodes of vestibular migraine in their 30s. Meaning they tend to be diagnosed in the 20s, but with their symptoms are the most severe or the most recurrent when they are in their 30s. Some general risk factors for vestibular migraine are that among a series of patients who have migraine with headache, about 20 to 33% of them report vertigo. And about a half to 2/3 of migraineurs suffer from motion sickness, which can also have to do with vestibular migraine. And another big risk factor is the family history, which, as I showed earlier, can be passed on through different genes, resulting in people be having vestibular migraines. Typically, when it comes to diagnosing vestibular migraine, it is a diagnosis of exclusion, meaning you've sort of ruled out everything else. But potential symptoms of vestibular migraine are ataxia spinning vertigo, nonspecific dizziness, a lightheadedness, a motion-provoked dizziness, which with increased motion intolerance. Patients can also describe an unsteadiness or a spatial disorientation, along with other classic migraine symptoms. Classic migraine symptoms tend to occur in about 10% of people with vestibular migraine, and they can include vertigo, tinnitus, double vision, dysarthria, auras around the eyes, photophonia, and photophonia. They can also have nausea and or vomiting and a pulsating pain. But again, the actual headache may or may not occur. These symptoms can last pretty much as long as they want. They can last seconds, minutes, hours, days, or they could happen all the time. But something that we learned in Dr. Pasquesi's Vestib class is from the Committee for Classification of Vestibular Disorders, the Barnary Society, and the Migraine Classification Subcommittee of the International Headache Society back in 2012 said that vestibular migraine is one diagnosis and probable vestibular migraine is another. In order to diagnose vestibular migraine, they say that the person has to have at least 5 episodes with vestibular symptoms of moderate or severe intensity lasting 5 minutes to 72 hours. They have a current or previous history of migraines with or without an aura, according to the International Classification of Headache Disorders. That they have one or more migraine features with at least 50% of vestibular episodes. These features can include a headache with at least 2 of the following characteristics: one-sided location, pulsating quality, a moderate or severe pain intensity, or aggravation by routine physical activity. Another potential feature is that photophonia or phonophobia, as well as a visual aura. Another classification to diagnose vestibular migraine is that no better accounted by another vestibular or ICHD diagnosis, meaning, again, that it is a diagnosis of exclusion. But for those who are diagnosed with a probable vestibular migraine, they have majority of the same symptoms. They have just limited, they only have to meet the criteria of the second 2 things listed for vestibular migraine, as opposed to all 4 classifications of vestibular migraine. But they also have to have at least 5 episodes with vestibular symptoms of a moderate or severe intensity lasting 5 minutes to 72 hours, and that it has to be diagnosed via exclusion of all other vestibular or ICHD diagnoses. When it comes to our audiological testing, audiograms, the patients may or may not have a hearing loss. It is said that 14% of migraineurs have a hearing loss, but typically hearing loss is not associated with vestibular migraine. So they pretty much have a hearing loss due to some other cause, whether it's noise exposure, ototoxicity, aging, etc. But generally, their otoacoustic emission testing correlates with the amount of hearing loss. So if they have no hearing loss, then otoacoustic emissions are normal. Admittance testing does typically show type A tympanograms, therefore normal, and their reflexes tend to correlate with the hearing loss as well, and they also show no evidence of reflex decay. Typically, ECOG testing is not diagnostically useful with vestibular migraine patients, but it is sometimes used only in the case of trying to rule out Meniere's disease. That being said, auditory brainstem responses can be used to help with vestibular migraine diagnosis because they typically show a prolonged absolute and interpeak latencies in those with a hearing loss. So vestibular migraine patients who have normal hearing tend to have a normal ABR, but if they have a hearing loss, then they do tend to show a prolonged absolute and interpeak latency in those with hearing loss. When it comes to the vestibular evoked myogenic responses or VEMP testing, they have very varying results. Some have reduced amplitude, some have normal latencies, some have everything's normal, some have a combination of reduced and normal. It all just depends. For VNG testing, according to Furman et al. Back in 2003, 10% of vestibular migraines patients have spontaneous nystagmus, 18% have positional nystagmus, 25% have a unilateral weakness in caloric testing, 16% have a abnormal directional preponderance with caloric testing. 54% of vestibular migraine patients have rotary chair directional preponderance results that are abnormal. And 30% show a central finding when it comes to the VNG. Overall, the VNG can show downbeating nystagmus, And OPK testing for these patients may evoke motion sickness, which, as I stated earlier, can affect vestibular migraine. When you are testing these patients when they are symptom-free, you may not get any of these results. They may have a normal UVNG. So it's just important to keep that in mind. When it comes to posturography testing for patients with Meniere's disease, they tend to just show a progressive difficulty in the more challenging positions. So if they have, both their eyes closed and the floor is moving below them, that's going to be the most difficult for them. As for potential medical evaluations for people with vestibular migraine, imaging is sometimes used to rule out other central pathologies and to rule out retrocochlear lesions or pathologies. Medical treatment for vestibular migraineurs are aimed at addressing the underlying cause for the migraine condition. But some of these medical treatments can include medications such as calcium channel blockers, beta blockers, and trilysic antidepressants, as well as several others which include Botox injections. Some of these patients may also undergo vestibular rehabs and general lifestyle modifications such as dietary changes, which means avoid caffeine, alcohol, nuts, hard cheeses, aspartame, chocolate, MSG, red wine, and scotch. Another lifestyle modification can be similar to that of Meniere's disease, so maintaining stress, maintaining good sleep habits, etc. Audiological treatment for patients with vestibular migraine is solely dependent on whether or not they have a hearing loss. Hearing aids would obviously be recommended if they have a hearing loss. And again, the type and style of those hearing aids would be highly dependent on the hearing loss, on the patient, and the patient's needs. On to some case studies that I found. The first one is a case study for a patient with vestibular migraine. So she is a 48-year-old female who is complaining of worsening dizziness over the last 6 months. She has a history of migraine as a teenager, but no episodes since her early 30s, so about 18 years ago. She has dizziness that occurs as lightheadedness and a disequilibrium along with photophonia, phonophobia, and nausea, but she has no headache. Test results for this patient show a normal physical exam, a borderline abnormal caloric weakness in the VNG, and then rotary chair shows an abnormal directional preponderance, all of which things are things that I mentioned earlier with the test results for patients with vestibular migraine. So therefore, this patient was diagnosed with vestibular migraine, and they received the following treatments, which included decreasing her dietary intakes of foods that might be provoking her migraine, as well as she was prescribed a vestibular suppressant medication for an as-needed basis, which hopefully isn't something she will take regularly. She'll only take it when she's in the most severe cases of her vertigo. The next case study I found is for a Meniere's disease patient. The case history includes he is a 70-year-old male. He has spontaneous episodes of true vertigo with nausea and vomiting lasting anywhere between 1 and 4 hours. He has a fluctuating hearing loss on the right side, bilateral tinnitus, and then he is completely symptom-free between these attacks. And then, as you can see in the picture, we have an audiogram that shows a moderately severe sloping upwards to a minimal sensory neural hearing loss from 250 hertz to 2000 hertz. sloping back down to a severe sensory neural hearing loss from 3 to 8,000 hertz in the right ear, and a mild sloping upward sensory neural hearing loss from 250 hertz to 2,000 hertz, again sloping back down to a severe sensory neural hearing loss from 3 to 8,000 hertz. He has normal tympanograms. His acoustic reflexes, correlate with the hearing loss. And his word recognition scores in that right ear is significantly worse than that in the left ear. In the right ear, he scored a 64%, and in the left ear, he got an 80%. And both ears were presented at a loud level of 105 dB, which, if you look in the corner, looks like it is around his LDL levels. So it's definitely very loud. The case also said that the VNG testing showed normal ocular motors, some spontaneous right beating nystagmus, and a right bilateral weakness with warm, cool, and ice water. This case also showed some rotary chair results and posturography results, which can be seen here on the slides. But just to briefly go over them, the rotary chair results show a high phase lead in lower frequencies with the left greater than right velocity asymmetry. This suggests a right irritative Meniere's lesion. Gain was normal, suggesting that the likelihood of a bilateral impairment is minimal. Posturography results show are normal for his age. More difficulty with conditions 5 and 6, which are the two conditions that rely most heavily on the vestibular system. Again, this suggests that a minimal bilateral vestibular involvement. So they're assuming that the test results suggest that the Meniere's disease is just affecting that right ear. That case didn't show any treatments for that patient, but I did also find an article by Teji et al. With 2 more cases that are a little bit less textbook than the last 2. So for the next patient, she was a 42-year-old female. She suffers migraines with auras. The first attack at age 20, and they typically occur before menstruation, which that points towards vestibular migraine. She has a family history of migraine. She has rotational vertigo that occurs and lasts minutes, upwards to 1 to 2 hours. Again, that also, along with the other symptoms, floats towards vestibular migraine. But she does have occasional right ear fluctuating hearing loss. With the audiometric testing was done, showed a right-sided low-frequency hearing loss, sensory neural hearing loss, which points to Meniere's disease. She also has migraine and vertigo that never actually happen together. She has tinnitus that increases just before the vertigo attack. She has a right-sided caloric weakness and normal CVEMP testing. So right there, that case, she has both symptoms that would point towards vestibular migraine and symptoms that point to Meniere's disease. And that right there, that patient alone just shows you that there is a correlation between the two pathologies and that sometimes they are a bit hard to diagnose between. And similar to patient 3, patient 4 is a 59-year-old female with a long history of migraine between the ages of 23 and 50, which is when she hit menopause. She has various episodes of rotational vertigo lasting about 2 to 3 hours. Hearing loss on the left side, which increases during vertigo episodes. Her audiometric results showed a low-frequency sensory neural hearing loss. She had a 40% unilateral weakness in caloric testing. In this case, they did do a head impulse test, which was positive with a corrective saccade towards the right side, and normal CVEMPs. Again, this patient has both symptoms and test results that can point both towards vestibular migraine and Meniere's disease, making the diagnosis between the two a bit confusing. And while this article didn't actually state which pathology each of these patients was diagnosed with, both of these patients fit the American Academy of Otolaryngology head neck specialist criteria for definite Meniere's. They both were started on preventative therapy for Meniere's, along with a salt-restricted diet. This treatment didn't actually stop or reduce any of their vertigo episodes, but both of these patients were then put on migraine medication, which did show a huge decrease in vertigo attacks in both patients. For one of these patients, their vertigo attacks stopped completely when they came in for I believe it was a year, either 6 months or a year follow-up. She had no attacks, and the other patient had 1 or 2 in the same amount of time. So that right there just showed you that the vestibular migraine medication was more beneficial for these patients than the Meniere's disease medications. Okay, so similarities between both Meniere's disease and vestibular migraine. It is something very important to note that about 50% of people with Meniere's disease also meet the criteria for migraine, and that's according to Radke back in 2002. They do have similar characteristics such as rotational vertigo, and they can both be symptom-free between attacks. And then according to Teggi et al. Back in 2010, migraine is capable of mimicking early stages of Meniere's disease, which will make it incredibly difficult to diagnose between the two, especially knowing that vestibular migraine is a diagnosis of exclusion. You sort of have to rule out everything else before you can do that. So if it is vestibular migraine, but it's mimicking Meniere's disease, and you treat for Meniere's disease, those patients who actually have vestibular migraine might not see any benefit. But some things to keep in mind as to how both pathologies differ are some of the symptoms, such as photophonia, which is something that typically only happens in vestibular migraineurs. And then you have roaring tinnitus, which is something that typically only happens in Meniere's disease patients. When it comes to test results, one big indicator could be the hearing loss. Yes, it is possible for vestibular migraineurs to have a hearing loss, but for Meniere's disease patients, they always have a low-frequency sensorineural hearing loss or worse hearing loss, just depending on how, late in the game they are with the Meniere's disease progression. And then their vestibular testing. Migraineurs tend to have a lengthened VOR time constants with rotary chair, as well as lower gains with rotary chair testing, whereas Meniere's disease typically have a larger directional preponderance with rotary chair. And then Meniere's disease, they tend to have a larger caloric weakness than vestibular migraineurs. Vestibular migraineurs can have a caloric weakness, but it's more, according to the research I found, it tends to be more of a borderline weakness, whereas with Meniere's, it's a more substantial unilateral weakness. So that being said, that is everything I have. This is my list of references. And a big thank you to everyone, and I hope everyone's doing just dandy today. Enjoy the rest of your day.